Good evening, all. Myself, Dr. Amrit Mashri, third year resident from BJMC Ahmedabad. My today's topic is stoma appliances. Stoma means an opening in the abdomen that can be connected to either the digestive system or urinary system to allow waste such as urine or feces to be diverted out of the body. Main type of stomies are colostomy, ileostomy, which are for feces, and for urine we have Eurostomy. Types of stoma, it can be temporary or permanent. Permanent stoma is the end stoma, and temporary stoma can be loop stoma, double barrel stoma, end stoma, tube cecostomy, or blowhole cecostomy or colostomy. The first picture is showing the end stoma, which can be either colostomy or ileostomy. Second one is the double barrel stoma. There are the two intestinal loop are present, proximal and distal loop. Third one is the tube cecostomy, in which we insert a tube or a small malleable catheter in the cecum. And the fourth is the loop stoma. Here we don't separate both the bowel loop. Instead of this, we create a stoma from the intestinal loop. And the one is the blowhole stoma, which is usually done in cecum or in transverse colon when there is a distal obstruction and there is much dilatation of cecum or transverse colon. Then we take the suture of the bowel wall with the skin and create a blowhole stoma. In history, the first we know the stoma pad was used in
Amrit, what is the difference between loop and double barrel?
Sir, in double barrel, there are two separate tubes of the intestine are present.
Completely separate. There is no continuity between the two bowels.
Yes, sir.
Whereas in loop, the posterior wall is continuous.
Yes, sir. Posterior wall is continuous in loop, sir. Yes, sir. Sir, first stoma pad, as we know, was used in 1930. A plastic cup-size pad was used, which was held in place by straps tied on the both side. After that, in 1950 until 1960, we use a black color latex stoma bag, which all are one-piece bag. There are no two-piece bag in the previous times. Parts of stoma bag. One is the stoma barrier. It is also known as wafer or base plate. It lies in contact with skin and it separates pouch from the internal conduit. It is made up of pectin. Wafer can be, sir, of two types. One is cut to fit. We can cut the wafer according to the size of stoma, and second is the moldable wafer. In this, we don't have to cut the wafer. We have to just mold it in the different form, because with the time, a person's stoma changes its size. If patient's weight gain is occur, then the stoma size also changes. So we can mold according to the patient's stoma, sir. Pouches can be open end and closed end. Open end pouch are drainable and closed end pouch are disposable. We can't drain content. They are single use pouch. After one time use, they have to dispose. Filter, it is made up of charcoal. It prevents ballooning because it gives a rent for air to leak out from the stoma bag. It also contains carbon, which neutralizes odor. Stoma clip, they are less costly. Used in an open stoma bag, they can be applied at the open end to prevent the leakage. But since clips are not more secure, there is more chances of leakage due to slip of the clip. Type of stoma bag. One is the one-piece stoma bag. One-piece stoma bag, they have the barrier and the pouch not separated from each other. So advantage is they are easy to use, they are flexible, less bulky, they are adaptable to uneven skin. We can apply on the uneven skin and they are in quicker application. But disadvantage is frequent changing is required. There are more screens, or because of more frequent changing, the screen excoriation will be more here. and the less according to special need. There is one special type of one piece bag. It is one piece with window. Window is in center. It is a white color ring is seen here, which is a window. We can open the bag from here without removing the barrier, and we can look for the stoma. We can examine and we can give distal wash or bowel irrigation through this. Another is a two-piece stoma bag. In this, the barrier and the pouch are separated from each other, so there will be less skin sore because change frequency is less. They are better for special need if patient, and they are less frequent changing is required. A disadvantage is there are more chances of leakage because if there is uneven, if we don't use the proper size of stoma bag or stoma pouch according to the barrier, then it will be leakage chance will be more. The difficult to clean the flange, they are more rigid due to flange present in between, so they are not very, and they are inflexible and bulky in nature. Another is the bag with belt. We can use stoma bag with belt. It is a stoma bag with double belt. They are usually used for end stoma. They are easy to apply. They are cost effective because frequent changing is not required. The uh, charges of the skin barrier and the wafer will be less. They are adjustable to according the size of the abdominal girth of the patient, and no flange is present in this. It is a belt, a two-piece belt bag with single belt. We have it. There are double belt is in here and single belt in this. Another is the open end. Advantage of open end are less changing is required. We can drain the content, easy to empty the bag for disposal, and they are preferred for ileostomy and colostomy because the output of ileostomy is more. So we prefer open end pouch in this. The disadvantages are difficult to drain thick content. If the content are very much thick, then they are not easily drainable, and the sudden leakage of content from the open end can occur, which will be cumbersome for the patient. It is the open end bag. The opening is present here, which is closed with the Velcro. One is the closed end. They are easy to accommodate daily lifestyle, and they are good for exercise, swimmer, and athlete. So because there is no open end, so chances of leakage are less. But disadvantage is replacement of bag is must. Replacement bag must be always present. Not good for high liquid output because we have to change, or frequency of changing will be increased. They require at least 2 to 3 times changing a day. More difficult to drain in public, and they are not useful for Eurostomy. One is transparent bag. Transparent bag are easier to check. We can check for stoma condition, whether stoma is functioning or not easily. Stoma is pink or not, or is there any prolapse, and there is less patient intrusion. But disadvantage is they are less discreet. The bowel or feces consent will be visible uh, to everyone. So that will be a socially not acceptable. Opaque bag, the advantage are they are more discreet but difficult to check. It is the opaque bag with belt, and this one is the transparent bag. One comes the convex bag. In this, the wafer has a depth of at least half centimeter, uh, which gives the advantage. It
Amrit,
accommodates. Yes, sir.
Amrit,
Yes, sir.
have you taken the I- ideal stoma bag? What are the properties a stoma bag should have, or a dressing?
Yes, sir. It will come. The how we should apply the
Okay, fine, fine. Continue. Okay, okay, fine.
convex bag. The advantage, it accommodates the flush stoma. If one stoma is flush to the skin, then we should prefer the convex bag. It is also good for retracted stoma. It adapts to the skin wrinkle and creases. It also adapts better for the surgical scar. It gives longer lasting seal. Moldable option is also available in this category, and it accommodates the telescoping of stoma. The disadvantage is it's expensive and less discreet. One is the flat bag. In this, the wafer or barrier is flat. There is no convexity. They are better for prolapse stoma and require protruding stoma of at least half inch. If stoma is not protruding half inch or 2.5 centimeter, then this bag, there is more chances of leakage of this bag. Stoma site selection, it depends on the physical condition. One is the physical condition, which include weight, patient's general health is and dexterity, whether patient is righty or left-handed or right-handed. It changes according to that. Social activity, patient's occupation, patient's sport participation, and cultural activity. Areas where we should avoid during the stoma application or stoma bag application, we should avoid any bony prominences. If any skin fold is coming in between, any previous sites should not be there. We can't apply easily stoma to the umbilicus. Bed line should be avoided. Previously irradiated skin and the pendulous breast, they should be avoided out of the stomal area. Visibility, the sites should be in reach and visible to the person. Choose a relatively flat area of 5 to 7 centimeter for stoma. In case of obesity, choose area in the upper quadrant. If the patient already has an stoma on one side, mark the new side 2 to 3 centimeter up or down to allow the belt if needed. Assess your position before going for any person for ileostomy or colostomy. We should do the stoma marking in different position, which will be helpful. We should examine in the supine, in sitting, in standing, and in bending. They are the 4 common position we should go for in every person. And if,
Amrit,
yes,
you
sir?
are talking about permanent stoma or temporary stoma?
Sir, in both kind of stoma, sir, we have to sir, position is very much important in end stoma, but in temporary stoma, we should we have to go for this, sir.
No. What are the plan indication of temporary stoma?
Sir, temporary sir, plan indication, sir, we go for if we going for any distal anastomosis. For protection of distal anastomosis, sir, we go for plan, sir, stoma, sir.
We are talking of temporary loop stoma.
Yes, sir.
In that case, will you get time for all this?
Sir, this is the ideal way, but if
No, nothing like ideal way. How many times in your 2 years practice in emergency you have done this?
Not a single one, sir.
Not a single. So what is ideal? It is not ideal. This is meant for a permanent stoma. Do you understand? This is only for a permanent stoma, not for a emergency or temporary stoma. Don't give wrong message. It is to be done for both. How can you do it for a emergency stoma, this thing? So what will you do when you have to do stoma in emergency?
So then there is we can go for the stoma triangle, which is
very
formed
good
by.
So have you slide of that?
Sir, here we can go here for stoma triangle.
So what is stoma triangle?
Sir, it is the triangle which is formed by 3 imaginary lines which join the umbilical, pubic symphysis, and anterior superior iliac spine, sir.
Very good.
If we are going for any emergency stoma, we should go in that area, sir.
Very good. Anything else in that? So permanent stoma, remember what I want to convey for all residents. Permanent stoma, usually you have time to plan. You should stand to the expert, particularly who is going to do stoma care. He or she will suggest the exact size according to patient. And these are the things they will keep in mind, including whether the patient is thin or fatty, whether the patient has abdominal apron or not, what is the normal activity of patient, what does the patient do? Do you understand? And whether it is on right side, left side, patient is right-handed, left-handed, those all are to be done for a permanent stoma. Temporary stoma patient can add up because it is going to for a 3 to 6 months at the most. So here it will be a surgeon's duty to create a site of temporary stoma. So you cannot have a measurement ideal, this, that, and 90% of the stoma in our setup is emergency stoma. So give the pointers for an emergency stoma care, positioning. One is triangle. Ideally speaking, anterior superior iliac spine is for another purpose. The pointer is that any stoma done in emergency is preferred below the transverse line drawn at the umbilicus, if it is ileostomy. If it is a colostomy, it should be above the transverse line drawn of the transverse colostomy above the umbilicus. Similarly, on left side, sigmoid colostomy should be line up because it will be convenient. One. Second, it should be away from any bony prominence, which are the simple pointer. You will not have a time for drawing this line, that line. So how much far away from anterior superior iliac spine it should be in a lower stoma?
It should be 4 to 5 centimeter far from the ASI, sir.
So there should be a space from any bony prominence after applying probable stoma bag. Do you understand? So there will be a space to apply the flange or the carry or the stick-on stoma bag, whatever you do. So after that, bone should not come in the way. So you should understand that is a very important point. This is what ideal, which is very difficult to follow in emergency. Okay, what else? If it is a stoma of a transverse colon, same principle should be applied for costal margin, right or left. Do you understand? So a draw imaginary line from anterior superior iliac spine to the umbilicus. It is like a site of appendix approximately. The difference is it is more medial than appendix. Why? The stoma should be brought out that way. It should cut the 1/3 of the rectus muscle. Do you understand? 1/3 of rectus muscle can be cut, and that will give a better stoma care. If you put away from laterally, it will become difficult to apply the stoma bag when it is lateral. So that is that. So you draw one more imaginary line, that is a lateral border of rectus. You understand?
Yes, sir.
What is known as a linea?
Linea semilunar, sir.
You understand? So it is a very important landmark for us. So umbilicus, linea semilunaris, transverse line drawn, and anterior superior iliac spine. If patient is fatty, you can go little higher up in case of creating a stoma. So in emergency, what other thing you will take care? That is the one more point. Remember, the site at the end is not very important in temporary stoma. Do you understand? The reason is it is going to go inside. So, but it has been observed when you create little bit more medially than laterally, parastomal hernia becomes less, and chances of development of retraction is also less. One more point, because of that it is in close proximity of rectus muscle, it helps for a better control of the stoma. In a flange stoma, again it is same. One more point, linea semilunaris is again an important point along with this all. So remember, this lateral border of rectus is very important point when we are creating a stoma. When this all goes to the of no use is when you do not have a proper loop to bring out any place. You understand? There is no adequate length of mesentery available. There is no proper loop which is available which you can bring out. Then you improvise. Do you understand? Then it is excuse to bring it out anywhere. What will you do in a worst scenario? Where will you bring it out in a worst case scenario?
Sir, if, in worst case scenario, sir, we can brought it out from the laparotomy wound.
Excellent, excellent. Keep this in mind. I would suggest that is one of the safer thing rather than to bring it out from later. It has its own disadvantage. But in a worst case scenario, you do not have a length of mesentery. Loops cannot be brought to the lateral, right? So another important point, the site of temporary stoma is also decided by length and availability of mesentery. Do you understand? Again, the same principle. A fatty patient will have a very thick mesentery which will not be mobile. So again, you will have to improvise and bring out place where there is a minimum traction on mesentery. One more point is that will you bring out it oblique or will you bring it out transverse?
Obliquely,
You
sir.
understand? We are talking of a loop stoma. Will you bring out oblique or will you bring out transverse?
Oblique, sir.
Why?
It will be, sir, more easier to brought out through the oblique method, sir. Hello? Am I audible, sir?
Yeah, but I think we lost sir. No. He had some issues with his internet, U broadband. Anyway, so
Sorry,
to
Gerald.
avoid prolapse and to avoid parastoma.
Yes.
May you have an internet જોડે problem?
ના એ જ અત્યારે ચાલે છે એટલે પણ આવી ગયું પાછું ના ફોન હતો હા okay, now I am audible.
Yes, sir.
Okay, so what was I asking?
Sir, the type, whether I should go for oblique or
Why
transverse.
oblique?
Why
Sir,
oblique?
because
Yes.
sir, the chances of stomal prolapse and hernia will be less if we going for an oblique one, sir.
Why it will be less?
Sir, the dead space created around the bowel loop will be less in if we go for, sir, oblique type.
So how it will be less than transverse? Remember, there is no difference as far as a parastomal hernia or anything is concerned. Do you understand? It will be same. It depends upon so many factors. We'll come to that later on. But the important point you should keep in mind is closer point. Because when we are talking of the stoma positioning, as far as the collection, the closer should also be kept in mind. And it has been observed. We are very used to doing a oblique. The reason is that it creates the less muscular weakness. Do you understand? When you cut the muscle, you can separate the muscles and create it. When you put a transverse, you will have to cut a partial muscle and partial sheath. Right? One more point, the direction of mesentery is when it is oblique, it is easier and less chances of development of necrosis. So people prefer the oblique incision and oblique stoma because of that. But keep in mind, transverse are easier to close. So when it is possible for a transverse, it is preferred like in transverse colostomy. We always put a transverse incision in an upper abdomen and oblique incision in lower abdomen. Understand this point. Both has its own merits and demerits. But when you bring it out upper abdominal stoma, right transverse, left transverse, you always put a transverse incision because the lie of mesentery is mesocolon is parallel. Understand this point. So twisting will be quite less. Same principle when you put an oblique, the twisting is less in small bowel. Again, this is ideal, but when it comes to the emergency, you can bring out anywhere by any means, but this is what is preferred method, right? Upper transverse, lower oblique. Okay, continue.
The ideal elective stoma should be below waistline, below umbilicus, as sir said, and they should be through the rectus muscle. But
Very good.
Yes, sir.
This is what is difference. Ideally, it should be through the rectus sheath muscle. Again, it will create a type of a valve when you bring out. So with the contraction, patient learn how to control the stoma permanent. And we have seen the patient in whom Okay. So this is that when it is a permanent stoma, you can bring out through the rectus, but many people do not follow this, understand this point. That's why pre-marking is important and prefer to go little lateral, because the rectus sometimes is so narrow that it will practically come in midline. So this is again not always followed. Better is you bring out through the lateral part of the rectus muscle. That is normally followed. Okay.
Overall, in general, loop colostomy will we go for in left or right upper quadrant. For ileostomy or ileal conduit, we go for right lower quadrant, and for colostomy, we go for left lower quadrant. A stoma site selection also depend on the body profile of the patient, which we have divided in the RIO. R stand for regular, I for inward, and O for outward. Regular body profile means the periostomal area is more or less level with the abdomen. Although the skin surface may be uneven, but the area level will be according at the level of abdomen only. Inward means the periostomal area sinks into the abdomen, creating a halo, and the outward means the peristomal area rises above the abdomen, creating a peak. So inward and outward will change our choices of the stoma bag. In inward kind of body profile, we have to use the convex type of stoma bag, and in outward, the flat one will be better. The stoma template, before applying to the stoma bag, for cut to fit size of the barrier, we have to cut the barrier according to the size of stoma, which we can measure with the stoma template. It comes in the different sizes and different shape. So according to the different stoma size or shape, we can cut the barrier. Different appliances and how we should apply them. First, before applying stoma, we should use the cleanser. It moisturizes and cleans the skin. First, clean the outer edge and then move toward the stoma. And it can be applied on the stoma because it helps in cleaning the rough area. Yes.
Amrit, have you
Yes,
made
sir.
any division for a loop stoma and for end stoma, or are they same?
Sir, I have mentioned it in earlier, sir.
Okay, sorry, I was not there. Fine, it's okay, no issue. That's why I was just asking. Fine. So, in nutshell, how does it differ? Go one slide back. This is the very important slide, I believe. Because when you create a loop stoma, the actual requirement of hole will be very large. Understand this point. So this you should keep in mind when you are applying. Because remember, permanent stoma patients do not come normally for a resident and the consultant for a daily change. Understand this point. Because they are usually so used to, they will do on their own. They don't, because they are very, usually what is more important for us is how to take care of an emergency stoma or the stoma we have created in the ward. And 90% of them are a loop stoma. So first thing you should understand is that the size will be much, much larger than actual end stoma. Because you were describing RIO, that is end stoma. Do you understand again?
Yes, sir.
But in loop stoma, there is nothing like RIO because we do not have that time. We have brought it out at the most convenient site. It will be usually oblique. So the bag should be cut that it will be fit the stoma, right? One more point. What other thing will be hindering when applying this stoma bag in a temporary stomy? You understand my question?
No, sir.
The point is that many loop stoma is brought out along with some
Yes, sir.
past of the either feeding tube or that which is kind of covering the loop, which is already attached. Do you understand?
Yes, sir.
Many times it is like that. So what will you do to that?
Sir, in that
You
case,
must
we
have
have.
seen.
Yes, sir. Yes, sir. Sir, in that case, we have to apply a bigger size stoma bag and we have to cut the flange more, sir.
Very good. One more point is that you can still apply it by taking that feeding tube inside the bag itself.
Yes,
So
sir.
that is not an hindrance to the appliement of the bag, but the size of the flange should be very large. It should accommodate. So if it is an emergency stoma, earliest when can you apply the stoma bag?
Sir, after creating stoma, sir, we should apply the stoma bag, sir.
I am
As
talking
early
of
as possible.
emergency. I am talking of emergency.
Sir, in emergency also, sir, when we create stoma, sir, we should
So
apply
what is normally followed? So do
Sir,
everybody apply the stoma bag immediately, or are there other options?
Sir, immediately we can also go for
Nahi, nahi.
applying a jalonate dressing on the stoma, and on post
So
op day one we can.
message for a resident here is very clear, and that is, so make it a habit to apply the stoma bag, as Amrut has said, as early as possible. Ideally would be to, before patient goes away from the operation table, stoma bag should be in position. The whole purpose of this lecture is that any type, any kind of stoma, there is a appliance available. Do you understand? You have to modify it accordingly. So it is not that you cannot apply, because it is habit of many residents and consultants that what they do is, hello, hello.
Yes, sir.
Yes, sir.
Yes. So what was I saying? That when stoma is created, you should immediately try to apply the stoma bag. Learn this one thing and it will be useful. Because the most of the time we have a habit, hamna to kya avanu che, kahin lagai rakho na gospis. What will it do?
Sir,
Why we should always apply stoma bag as early as possible.
because the leakage of content, or if stoma gut functioning, it will lead to skin excoriation, and
But suppose in 24 hours, will it cause skin excoriation?
no, sir. It will cause the surrounding soiling of the skin, sir, and chances of the infection will be more if we don't apply the stoma.
Very
bag,
good. The first point you should understand here is, when you create a stoma, how much time it takes for a sealing. You understand sealing? That means there is a creation of a barrier that content will not enter the peritoneum. That what you call sealing of the stoma.
Sir, it takes 3 to 5 days, sir.
Wrong. It takes less than 24 hours. Keep this thing in mind. Usually the peritonization occurs in 24 to 48 hours maximum. So what is a problem is, during that time, if the content leaks, it has a chance of going inside the wound very easily. So if you have applied the stoma bag immediately, the content will fall into the bag and does not soil the surrounding. So skin excoriation takes 7 days. It does not happen. Obviously, if it is a pancreatic or biliary, it can happen earlier. But in a normal antral fish stoma, it takes 5 to 7 days if it is not taken care. But understand what I want to say. If you just apply gospis, content come out and it does not fall into that. So it goes by the side of it and will soil the junction of the stoma with the skin and will go inside. And many a time, retraction of the stoma, infection of the stoma, or widening of the stoma occurs because of this initial soiling. Do you understand? So applying the stoma bag, even in a loop stomy, immediately is advisable. If not immediately, at least before stoma gets functional. But you can never rely when it will get functional. The point is that if you, once it start functioning and you apply the stoma, what will, by the time there might have already soiling and contamination of wound might have occurred. One point. Second point, isolated stoma in loop ileostomy we do not create. What we create is usually along with laparotomy. So I think Julie has written that is a contamination of main wound is also likely. Do you understand? And that increases the chances of infection. So it is advisable. You should apply the stoma as early as possible. If you have done in midnight, before the stoma starts functioning, you should start applying the bag, which will create a better barrier and causes less complication of the stoma. You get my point?
Yes.
It is a very important, it should be very clear message. Apply the bag as early as possible. If in the OT at the end of surgery, best. Not next day morning, at least before the stoma start function. We have a habit, stoma is not functional, null function, let us apply gauze piece, let it be there. What is exception? What is exception? Where you may not apply the stoma is early.
Don't know, sir.
Stoma bag, I think. And what I want to say is, in which condition stoma bags are usually not applied early? There are two. One is a pediatric patient, newborn patient, right? A patient having anorectal malformation or Hirschsprung, the pediatric patient usually, because they are more tolerant and chances of other things are less, so and they cannot tolerate stoma bag very easily. So in those patients, it is usually gauze piece, bag is not applied. Second, in particularly sigmoid colostomy or a transverse colostomy in some time, because the content will be so solid, chances of contamination is less. And in emergency, when it is done, it is usually done for some obstruction. So they are very dilated, edematous and omentum. So what you have bring out will be very, very big mass chunk, and a stoma bag may not be convenient to apply. Sometimes rare condition, this can happen, then that is okay, you do not apply bag. Otherwise, in all ileostomy, you should apply stoma bag as early as possible. Continue.
We have discussed the cleanser. After applying the cleanser, we should apply the barrier cream. It provides nourishment to the skin and keep the skin pH at 5.5. Help in the healing of the excoriated skin. We should first apply for a few minutes. We will keep it for 5 to 10 minutes. Then wipe it with the cleanser. After applying the barrier cream, we apply the Stomy powder, which is usually made of guar gum and methyl cellulose. It applied on the dry skin, also prevent excoriation. We sprinkle it around the stoma, and after sprinkling, we also keep it this for 5 minutes and wipe it with the cleanser. If after applying the stoma powder, we use the stoma paste. Used in the one-piece stoma bag usually, it seals the edge to avoid the fluid coming in contact with the skin. We should close the cap immediately after the use because many of the stoma paste contain alcohol, and we use the wet finger to spread the paste. Paste is also available in the strip form, which is non-alcoholic form. Elastic C-tape. After applying the stoma bag, we apply the C-tape all around the stoma. Usually a 2 C-tape would be enough for ideal stoma bag. It provides extra safety while doing movement and motion and prevent the leakage from the peripheral area of the stoma bag. One is the stoma deodorant. Many patients complain of bad odor from the stoma side. It neutralizes the odor, provide multi-lubricating effect, and keep the content at the bottom of the bag. And we put few drops and rub it gently to even application. After that, the stoma bag. Stoma belt is available in both one-piece and two-piece bag. It is of adjustable length. It provides extra security. And slide the belt under the patient's back and put the hook on the base plate on the both sides.
What are the parts of this bag? Describe the parts of this appliance.
Sir, one second, sir. Sir, one is the stoma bag pouch. After that, the flange.
What is flange? What is flange?
Sir, flange is which we applied on the skin is the barrier or base plate. On base plate, there are both side hook is present, which we apply the belt, sir. This is the removable belt, sir.
Why is normally not done this belt part? Again, you are describing end stoma.
Yes, sir.
So in emergency, it is not convenient. Why? Again, because of the laparotomy wound which is there.
Yes, sir. Wound will be, sir, in between, sir.
So this belt is for after once this patient is discharged, it can be applied, right? So what are the types of flange?
Sir, one is the sticking flange. Another is coming the non-sticking or colostomy kit, in which there will be no flange. and belt will be inbuilt. There will be two belt. I have described it in the previous slide. I will show
Okay.
it, sir.
Okay. Yes, I got it. I got it. Next types of flange I am talking. Yes.
And sir, one bag came in which the flange will be non-sticking to the skin. Flange will be there, but it won't stick on the skin. That also be used in the end colostomy, sir.
The
And
point that remember the part which is are usually in stoma part is three part. One is a bag itself. Second is a flange, and third is a material which will keep it in position. Do you understand? Flange come of two type. One is stick on, that will stick. Do you understand? Second is non-stick, which will be kept in position by belt. There can be a single belt, there can be a double belt. That kind of flange is very crude, usually not recommended, but the patient who cannot afford and coming from very remote area may not afford your all this cleanser, this, that, it's very difficult. And particularly when it is a more solid content, the non-sticking flange can be applied. But when it is not watertight flange, usually chances are there that patient may have a leakage. Do you understand? On the contrary, it is very cheap. Whereas this, what is the cost of this? There is a one trademark available that is known as a surfeit, which is a flange, thicker flange, which can be stuck and which will stay in a position for 3, 4, 5 days. Even sometime patient is careful for a week. But after that, patient will have to change the flange. The bag and the flange are joined by a locking mechanism.
yes,
Have you shown it?
sir, I have shown in previous slide, sir, the two flanges, sir.
Two flange nahi, locking. What is locking mechanism?
Sir, locking comes, sir. Sir, the flange will be on the outside and there will be a lock system on the, sir, barrier. We have to
So
lock
if
it,
you
sir.
rotate and it will join with it. So that back can be easily.
He showed it. He showed it.
He's shown it. Okay, great. Right? So remember the flanges are over. And what is the third part is? The bags. One is a bag. How do you apply flange on the bag? One you have said is a locking system. What other system? There is a one flange where the simple our bag can be applied by tied over by rubber band. So you can pass a rubber band and that will remain in position. Easiest way. You understand? Again, the very cheap. I have not photographed. I would have shown you. That is like a rubber ring, and there is a flange. It will stick on the flange, and in between it will catch the bag, which can even our simple bag can be used. So in emergency, that is a one more method of fixing when there is a locking is not available or those bags are tailor made and they are costly. So if you have a flange without pouting, only rubber band will cap it in the bag can be kept in position. So in emergency, it can be used and will be very cheap. Again, one more point is that this can be used in a plan. In emergency, sometimes it is difficult. So you can use directly stick on or the flange without sticking. The reason is that patient has a still done stomy immediately. The chances are there, it may become edematous, it may become gangrenous. So the stick on, the visualization will not be good. So you need a initially simple bag without this sticking mechanism or flange which is not sticky. The later on, this can be applied even in loop. These are the options. Okay.
Should I continue, sir?
Yes, please.
Another one is the protective sheet. It also helps to prevent leakage, and we sometimes apply protective sheet around the barrier to prevent the leakage from the peristomal area. And after changing the bag, when we are changing the bag, the gum which is present on the barrier or the adhesive material which is present on the barrier and the protective sheet, that can be removed with the adhesive remover spray. It is an alcohol based spray. These are the different material. It is a cleanser. It is paste.
What is content in paste?
Sir, paste is an sir alcohol based paste sir. More sir material sir I have searched but not found actually what it is made up of.
Usually it is a karaya gum, they call it.
Yes sir.
The sticking material is karaya gum. It has a two parts. One is sticking, not very badly sticking. If it is, can you use Fevikwik?
No sir, we can't use
Why
sir.
not? Why
Sir,
not?
sir, it will sir damage the skin sir. Skin will
So,
be
so here the sticking should be non-irritant and non-damaging, and it should not be very long-lasting. We don't need that much. So karaya gum is a very good material. The all particular paste are based on karaya gum. Even the tubes which are available additional, because sometimes you feel that skin is excoriated and to apply the directly flange is not easy. So you can make a layer of karaya gum and over that you can create a stomal bag, right? So keep in mind, mostly it is a karaya gum and similar material. Okay.
that is the ostomy powder, which is made up of methyl cellulose and guar gum. It is C-tape and the cleanser. It contains very lauryl sulfate and glycerol, which fragrant preservative other. One is the balloon testing. After applying the stoma bag, whether we have applied it correctly or not, or is there is any leakage or not. For that we do the balloon testing. Then after the application and to make sure we put the 50 to 100 cc of air through pump in the stoma bag and we lock it off and we check whether there is any air leaking from the periphery or not. If it is not, then it has achieved the proper seal. Stoma irrigation. We do stoma irrigation to empty fecal content or prepare bowel for surgery or any diagnostic purposes. It also help in controlling the odor. We usually transfuse in one go 1 liter of irrigating fluid, which commonly used irrigating fluid is tap water, normal saline, PEG, and glycerol nitrate.
What is the other name of this?
Sir?
What is the other name of what you are calling stoma irrigation? What is the other name?
Sir, it is distal wash, sir.
No distal. That's what I have asked you. It is not a distal wash, beta. Distal wash we are not talking just now. What is it? It is enema. Again, this all you have prepared is for end stomy. End stomy, like in per rectal you give a enema, here you have to give from here. So it is a kind of enema. Where you give by enema can.
Yes, sir.
Right?
Yes.
Because in distal, it's a different thing. Okay.
Technical issue in relation to the stoma bag application are
Yes.
one is the cost, because of ostomy powder cost around 400, barrier cream cost around 700, Brava paste cost around 640, one C tape cost around 90 rupees, one piece bag cost around 190, and two-piece bag it is more costly because plate charges around 400, bag charges around 270, and belt cost around 450. So two-piece bag is actually a costly one. Normal people usually can't afford this kind of bags.
No, bag and they can afford the paste.
Sir, no, sir, please.
How much one paste lasts? How much?
Sir, it lasts only, sir, two dressings, sir, usual.
Exactly. So remember, the recurring costs are very high. That's why I was describing the innovative method of a belt only without sticking. Usually, because the end stomy is when sigmoid stomy, this much of elaborate preparation is not required in a permanent sigmoid stomy, because the content will be more or less solid. Patient is usually aware of that. So usually simple flange with belt without any use can be done once the patient becomes used to. Remember, the skin excoriation is much common in ileostomy, which are usually, unless it is a proctocolectomy, are usually loop ileostomy. And we are worried for first 3 months, only for 3 months. There you can afford to have this powder, cream and everything, because it is not a long-term cost. But in a permanent stomy, this is very costly. So you should keep that thing in mind, because I know that if it is a permanent ileostomy, per month cost before 25 years was around 15,000. Now it has come around, I think, 5,000, 5,000. but still it is there. You should keep it in mind. All these material are costly, though it is available in the hospital, that's a different thing, but you should remember this point. Okay.
Second aspect is difficult application of appliances. If stoma is retracted or flush stoma, then usual stoma bag or the single flat plate barrier can't be applied. Then we should prefer for the convex type of barrier, which will be better. If stoma is recessed in the skin fold, if patient is very obese, then the stoma will be in the skin fold or separated stoma. When the mucocutaneous junction of the stoma is lost, then we should use the filler paste, which usually contains the, as sir said, the karaya gum to fill the gap, and after that we should apply the stoma bag. If there is a prolapse stoma, then we should prefer the flat bag, and if there is stomal edema, we should first give the cold compression before application of the stoma and put radial cuts over the adhesive plate to prevent damage to the intestinal bowel mucosa. If stoma is near the laparotomy wound, many times in emergency, we don't
Yes, yes,
place.
this is what is more pertinent
Yes,
for
sir.
us.
Sir, in that case, stoma bag application will be difficult. So we can do two things. We cut the wafer more towards the periphery instead of cutting it into the center, and we use the bridging technology, sir. In bridging technology,
it is not technology, it is technique.
technique, sir. Sorry, sir.
કોઈ
Sir,
technology
technique,
નથી
sir.
વાપરવાની. What is technique?
Technique.
So what it is? Yeah, what
Sir,
it
What
is?
it is?
In bridging technique, sir, we cut the small 1 to 2 centimeter size of wafer or paste, and we apply it around the main laparotomy wound on which side the stoma is present, sir. After applying, sir, then we apply the stoma bag. So there will be no chances of leakage of content from the stoma to the laparotomy wound, sir.
So it prevents, it's like a
So
dam. It will, yes, Apurva, please
Yeah.
carry on.
Yeah, so what we were doing is that we
Yes.
either use a feeding tube or a IV set. We cover it completely with a this sticking plast or micropore and create a small bridge. We have attached both the flanges to the micropore to the skin so that a raised edge is created so that the fecal content does not follow into the laparotomy scar.
Okay, continue.
One is to prevent silver paint. In reality, it is an aluminum paint, not a silver paint. It acts as a skin barrier, prevents skin excoriation due to stomal effluent, and it is a very cost-effective method to prevent skin excoriation in Eurostomy patients.
Amrit, again, I would like to differ. Apurva, would you like to say something or should I? The point is that this is not for a stoma. Understand this point. We do not, we were never using for a stoma. Only time when we used to use was if there was a perforation near the base of the stoma, instead of the contents were coming by the side of stoma and end was not coming, then there is a role of this barrier. Otherwise, applying of the stoma is proper. Of the stoma appliance can be done in those cases. But particularly in this case, when there is a site of it's like a fecal fistula then. And normally we used to use in a case of enterocutaneous fistula, early time proximal fistulas as a skin protection.
One is the PRN dressing. PRN means the pro-re nata dressing, which is a Latin phrase.
PRN, PRM nathi.
Yes, sir, yes, sir.
Yes, PRM case. It is PRN.
Yes, sir. Which is a Latin phrase meaning as the circumstances arise. Means we do it if we apply this kind of dressing, the frequency of dressing decreases, and we should do the dressing if dressing is soaked, more soaked than. It is used historically in a heavily exudative wound. First, we have to clean the wound. This is a patient of burst abdomen. We have first cleaned the wound. After that, we have applied a single layer of wet gauze with NS. After that, we applied a single dry gauze. After we apply a mop above that, and we create an artificial belt with the help of two piston, and we tied the two piston with the at the both hand with the band, rubber band. We can do the wound is heavily exudating, then we can do the suction after opening the belt, sir. This will,
Amrut,
sir. Yes, sir.
Amrut, Apurva must be wanting to say something.
No, the first thing is not a gauze piece. You should be putting in a Vaseline gauze piece so that it does not stick, because this dressing we don't use for mainly, we use it only for fecal fistulas or intracutaneous fistula where the exudate is very high. Not for, and more than exudate, it causes skin excoriation. See, routine burst abdomen, the skin is not going to be excreted by the ascitic fluid or the peritoneal fluid. So in that case, you can put a simple layer dressing. You don't need to stick all these things. But when it is lot of fecal material is coming, especially the terminal ileum or the jejunal, then it is difficult to, you cannot even apply the sticking plaster or the micropore, it will excoriate the skin more. So in those cases, we use it, and the first layer should always be Vaseline gauze piece so that it does not stick to the bowel.
Yes. Again, here there can be one belt or two belt also.
Yes, sir. There can be two belts, sir.
Two can. The purpose is that depends upon the length of the wound. It can be one or two. One more point. Only PNR is useful only that the resident will be better. દરેક વખતે પટ્ટા કાપી કાપીને લગાવવાના નહીં. ખાલી ઉપરનું ખોલીને અંદરનું બદલી કાઢવાનું. And I have seen resident, including myself, we used to teach to the patient's relative કે આ પટ્ટો ખોલીને લગાવી દો એમ. From that, there's a PNR dressing as developed. The one more point, it is always accompanied by other method of prevention of skin excoriation. Either you apply a helix spray, you can apply aluminum paint, or you can create a large paste, which we used to was the glycerin maxal paste we used to, right? We used to make a glycerin maxal paste and thick layer of that and apply it over that. I think, was it a glycerin or something else, Apurva? I have forgotten.
No, sir.
Maxal to वापरता શું કરતા है ना?
ના સાહેબ, એક મિનિટ.
અરે હેમંતલાલ અનમ્યુટ કરી તમે બોલો. તમે બહુ કર્યા છે ડ્રેસિંગ.
ઝિંક ઓક્સાઇડ.
Zinc oxide or
Zinc
glycerin.
oxide. Yes.
હા,
Why the
ઝિંક ઓક્સાઇડ.
હા, બીજું બી ક્યાં આવતું હતું? અમૃત, can you see the Dr.
Yes,
Hemant
sir.
Patel? We have done, I think, hundreds of the PNR dressing. What do you say? PRN dressing.
Yeah. Yes.
We were co-resident, by the way. So we used to do a lot of dressing. And at that time, the purpose is why we are discussing this. In today's scenario, its value has decreased. The reason is we have a fistula manager. Understand this point. When the fistula manager is not available, you have to improvise. The one of the important improvisation is PNR dressing, PRN dressing. The reason is that it decreases the workload. Second, patient himself or the relative can change this without changing inner dressing. You every time do not change whole dressing. Only the outer dressing, which is outside the Vaseline gauze, is changed. So patient's relative can also change this without much of a problem. And if it is not soaked, you can apply the saline over it and it can be useful. Sometimes the whole wound is open, then this can be useful. But remember, it should always be accompanied by a material which will prevent the skin excoriation, because this is not airtight or anything.
Yes,
The skin excoriation or the spillage of content is bound to occur. In those cases, surrounding skin should be protected either by zinc oxide, zinc oxide, or a paint, or Karayagam if the patient is affording. If Karayagam was available at that time, it was costing around 700 rupees per tube, right? Or any other material which acts as a barrier. Okay.
Fistula manager, it is misnomer. Actually, it is a wound manager.
Very good.
Goals, we use this for the skin protection of the wound. It according to the patient's comfort and mobility. It containment of the drainage and the order, and the accurate measurement of the effluent, how much the output will be, and cost containment. We apply once and we can keep this for 1 week at least if there is any no other damage, sir. So there are types and part. Usually fistula wound manager come in 3 types: mini, midi, and maxi. And it contain pasta. One is the removable lid, which is applied on the uppermost past. Below this, there will be a drainage bag. There will be drain port. It can be either a single drain port or a double drain port. A tracing guide. There will be an accessory. There can be accessory port and clamp, and pump will be there, sir. Sir, we prepare the wound as we prepared for the stoma bag. After that, sir, we apply the tracing guide on the wound, and we trace how much the length and area the wound should be, and we trace it on the sheet. After tracing it on sheet, we cut according to the wound. After cutting, we apply the wound bag on the abdominal wound, and before after this, we apply the closing lid. Upper lid. Accessory port can be put on the uppermost part, which can be used for feeding jejunostomy or for any distal bowel irrigation. Instead of frequent closing, sir, we can use this port for feeding jejunostomy or any other tube if we want
Or
to put.
fistuloclysis.
Yes, sir, fistuloclysis.
What is fistuloclysis?
Sir, in sir, we put dye.
No dye. Dye આમાં કઈ ના આવે. તે કયું એ જ? Priya is help.
Irrigation.
Help you.
Irrigation, sir.
No irrigation. So when the fistula is relatively controlled, there is only one proximal opening and one distal opening, or you know that there is nothing beyond this distal opening. You can pass a catheter, Follis catheter, anything, which will go through this port. So what content, particularly bile, this is usually useful in proximal fistula. For distal fistula, the loss through the fistula is less. But in a proximal, like a jejunal fistula or biliary fistula, what we do is we apply the fistula manager and pass a catheter to this port and pass into the distal port and inflate by 2-3 mm by Follis catheter. So whatever content comes from proximal and collected here can be put back inside the bowel, which is known as a fistuloclysis. You can call it refeeding also. You understand? This is the very important. What do you do? Feeding jejunostomy. But in many of the cases of fecal fistula, feeding jejunostomy is not done. So this will act as a feeding channel, which is known as rectoclysis. That means you inject the fluid through the rectum. This is a fistuloclysis. Okay.
Eurostomy, it formed from a section of ileum used to form a conduit into which the ureter are attached and urine will be coming out from there. It is always a permanent one. Mucus secretion will also be present with the urine because we use ileum as a conduit and mucus secretion will be from there. We use a pouch with tap in urostomy bag, and the bag of urostomy should be changed on alternate days, so it is costly, sir. So that's it from my side.
Okay. Apurva, would you like to say anything? Add anything?
Now, one thing, why it needs to be changed every alternate day? Is it only a hygiene part or something else?
Sir, it's hygiene part, sir, because our urine output will be around, sir, 1 to 1.5 liter. And if we keep the same bag for more days, sir, the chances of infection and the loss of ileal conduit will be more, sir.
Okay.
So it is actually ileostomy, but why it is known as a urostomy?
Sir, because we attach ureter in the ileum and the urine output will be there, sir.
So it is through the ileal conduit. What content coming is only urine and nothing else. That's why it is urostomy. So difference, one the Apurva has asked, what other difference is there from the ileostomy, what we call?
Sir, the
measurement is very important. Do you understand? It is a very important. Urine output measurement is very important because it has its own complication. So ideally, if you see urostomy, it has a marking nowadays also showing the like a euro bag. 500 ml, 100 like that, because you have to measure. When you normally apply stoma or the ileostomy, there is no need to exactly measure how much output is there. What we are concerned is it is functioning or not.
Yes.
Do you understand?
Yes, sir.
Okay. Apurva, I think it should be all right.
Yes, sir. Yes, sir. Thank you, sir.
Thank you.
We'll leave that.
Okay.
Thank you, sir.
Thank you, sir.